afternoon, everybody. My name is Sarth. I'm the Orthopedic and Surgery Trauma Research Fellow at St. Francis Health System in Tulsa, Oklahoma. And today I'm presenting a project I did called Retrospective Analysis of Pre-Hospital Needle Thoracostomy. So needle thoracostomy is an intervention used to treat attention pneumothorax, and it's commonly employed in the pre-hospital setting. Attention pneumothorax occurs when air accumulates in between the visceral pleural of the lungs and the chest wall, and it causes compression on the lungs and the heart and the internal structures in the thoracic cavity. And few of the symptoms include chest pain, hypoxia, tachycardia, or absent breath sounds. Eventually, as the condition worsens, it can cause tracheal deviations, JVD, ultimately leading to obstructive shock and hemodynamic collapse. It occurs at an incidence of about 0.2% a year, and it has high complication rates if it's not performed appropriately. The procedure is performed in the pre-hospital setting, so a lot of the clinical evaluation is performed by EMS. So whoever is being trained to do this procedure does not have the luxury of having all of the hospital resources with them. So it is clinically challenging in a trauma setting to evaluate chest trauma along with head injuries or other injuries that the patients could possibly have. So it's commonly performed in a few places. It's performed either in the second intercostal space, mid-clavicular line, or the fourth or fifth intercostal space, anterior axillary line, or the mid-axillary line. And that's kind of up for debate as to what place is optimal. The guidelines in Oklahoma and Maryland kind of vary in the sense that in Oklahoma, we use the second intercostal space, a mid-clavicular line. In Maryland, it's age dependent, where if you're under the age of 15, they prefer the second intercostal space, mid-clavicular line. If you're over the age of 15, they prefer the fifth intercostal space, anterior axillary line. And above all that, according to the International Trauma Life Support Guidelines, they prefer the fifth intercostal space, mid-axillary line. So you can see that the location is kind of up to debate. Each location has advantages and disadvantages as well. So there isn't a perfect procedure or location for this. So the project that we did, the purpose for this was to scrutinize the prevalence of pre-hospital needle decompression from one tertiary care center over 8 years to examine their trends, efficacies, and pitfalls. And the hypothesis was that needle decompressions were being performed inaccurately in the pre-hospital setting, meaning they were being performed in instances where it was not indicated. The methods of this procedure was a retrospective review. We looked at 90 patients who arrived at St. Francis Hospital. We looked at their charts on Epic as well as their run sheets on the EMS reports. And we looked at all the labs, we looked at the narratives to see why the procedure was being performed. So here are the results we had. We had a total of 90 patients. The majority of were male. Majority were transported through ground transport. A lot of them were motor vehicle accidents, and the majority of placements were in the second intercostal space, mid-clavicular line. After they arrived at the hospital, you assess them to see where exactly the injury was. Was it a hemothorax? Was it actually a pneumothorax? Was it actually a tension pneumothorax? So we found that of all the patients who had a who had a catheter placed, 57 of them received chest tubes, and 37 of them actually had a pneumothorax after arriving to the hospital. After we looked at the run sheets of EMS, and we looked at why exactly EMS wanted to perform this procedure, we found that the most common indication was absent breath sounds by far, along with hypoxia and occasionally hemodynamic instability or hypotension. And about half of the cases, or more, slightly more, EMS reported improvement. So what does that tell you? If you have absent breath sounds, which can be present in a lot of instances, especially in chest trauma, hypoxia can also be associated with a lot of things. If the patient has COPD, for instance, you can have EMS assessing for absent breath sounds, where in reality, it's just hard to hear, or they have head injuries, which could cause hyperventilation, or other things as well that could be confounding. So according to our results, we looked at the vital signs prior to the intervention being done and after intervention being done. Now, the challenge of the project that we had was that not all the information was available for every patient, meaning that if we're looking at the vitals prior to needle thoracostomy and after, you have to have the vitals for that, and not all of them did. About 44 had a systolic value prior to that intervention being put in, as well as heart rate, as well as oxygen saturation. So even though we had a large sample, about half of them are kind of cut out since they don't have the information. But even then, we still have a relatively large sample that we can use to analyze. So if you look at their lab value, their vital signs, the median systolic blood pressure prior to needle decompression was 110. The median diastolic was 68. Median heart rate was 103. The median oxygen saturation was 92, and the median respiratory rate was 24. Now you look at that and you say, okay, are these guys really suffering from tension pneumothorax? Because when you have a tension pneumothorax, you're hemodynamically unstable. You can't breathe. You have compression on the heart and the lungs. And is it indicated at this time? It's hard for us to say because we're not in the preclinical setting, but you ask yourself, should you do it or should you not? And they're not without injuries. You look at all the complications in the literature, you can see, if you're in this second intercostal space, mid-clavicular line, you're near the heart. And there are cases where it's happened and they've had a cardiac tamponade from that, as well as if you're in the anterior axillary space or in the fifth intercostal space, you can hit the liver as well. So all of these complications can happen. And a lot of the time, even if you place a catheter in the lung, it's not all the way in. So if you look at the results that we had 7 placements where it wasn't actually through all the way, or they fell out. So even if you're doing the procedure, you have complications for it, you're not going to be 100% accurate all the time, but we want to optimize the accuracy to make sure, everyone who's being treated for a tension pneumothorax is being treated appropriately with the lowest complication rate. So if you look at all the patients we had, there were 9 patients who had an SpO2 under 92% or a systolic blood pressure under 100. So overall, the purpose of this was to evaluate and kind of see what the preclinical indications are and why we were doing needle decompressions in the situations that they were happening in. The most common indications were the absence of breath sound and hypoxia. Hemodynamic instability was not often present, and improvements were sporadic. You know, it's hard to say if the patient improved. A lot of the EMS reported improvements, which was subjective, but is that enough to warrant a tube in their chest? You know, so. And a lot of the times you can have confounding variables as well as to how you have absent breath sounds. If you have a hemothorax, for instance, the blood is also occluding the chest wall. So, you know, it'll be hard to hear breath sounds. A lot of the EMS was like, oh, so we have absent breath sounds, we'll just tube them or put a needle in their chest. But these procedures have complications, and it's important to take those complications into account. And you want to optimize the accuracy of catheter placement so that we reduce the risk of complications and accidents in the pre-hospital setting, because that just makes it worse for EMS, for trauma surgeons or EM surgeons or EM physicians in the hospital. The limitations were the fact that not all the information was present in the EMS charts. You know, we didn't have lab value. We didn't have lab values every 30 minutes for all the patients. We didn't have lab values or vital signs for every patient prior to the catheter placement or after a catheter placement. But even after all that, we had about 44 patients who had all that information. So obviously having projects in the future that have a larger population would be helpful, as well as looking at the BMI along with the placement of the catheters is also helpful, because the chest wall thickness in the mid-axillary line, second intercostal space, is larger. So your chances of penetrating are lower. So having larger projects that look at all these factors could help shed some light on how to properly address tension pneumothorax in the pre-hospital setting. This is my work cited. Appreciate you guys having me today. There could have been. That's not something we accounted for. But I mean, we included all of the locations that was performed in the EMS run sheet. Sometimes it wasn't even recorded, so it's hard for us to say. Oklahoma is not the most forefront when it comes to like being on top of healthcare. Unfortunately, I have to say that, but it is what it is. But I mean, so I don't think it's changed that much. I think that if anything, it kind of shows us, you know, how it was and how we can improve in the future. I don't think it's, no, I don't think so, because I don't think it's going to change our results per se. I think that more importantly is to educate pre-hospital clinicians that this is like a prevalent and it's there. So if it's up to them, you know, like the intervention would have to come from the hospital to EMS services, which is often a private group that isn't funded from the government. So they would have to be willing to make those changes as well, which is a long process to do. And, you know, we have presented a few of this information to EMS providers and stuff. Hopefully they'll make the change, but it's not up to us as a hospital per se. But yeah, appreciate you having me.